Welcome. After discussing about the classification, risk factors and pathogenesis of age-related macular degeneration or AMD in the previous session, in this session we'll be discussing about non-neovascular AMD. We'll start with age-related changes in the fundus which are considered as normal and not as part of AMD, and these include loss of foveal and foveolar reflexes, a few small hard drusen, depigmentation and irregularity of the retinal pigment epithelium resulting in tigroid appearance of fundus with increasing visibility of larger choroidal blood vessels and peripapillary RP atrophy. On fluorescent angiography, there is increase in size of the foveal avascular zone. On enhanced depth imaging or swept source OCT, there is decrease in choriocapillaris thickness and total choroidal thickness, but outer choroidal thickness does not decrease. On indocyanine green angiography, the choroidal arterioles appear fewer in number, thicker and straighter with fewer branching, and on fundus autofluorescence, there is increased autofluorescence from increased amounts of lipofuscin in retinal pigment epithelium. The natural history of non-neovascular AMD has an early stage with Drusen as seen here in this clinical photograph, and RP abnormalities in the form of hyperpigmentation, hypopigmentation and atrophy, which is known as non-geographic atrophy, and a late stage characterized by geographic atrophy. Drusens are the defining lesion of all forms of non-neovascular AMD. Patients with drusen are usually asymptomatic, but drusens may affect the overlying photoreceptors, leading to mild to moderate loss of visual acuity, loss of contrast sensitivity and color vision, impaired sensitivity in the central visual field as determined with microperimetry, and impaired dark adaptation. Delayed dark adaptation is said to be the first biomarker of AMD, and microperimetry shows that relative decrease in sensitivity does not consistently occur over drusen, but rather corresponds to locations with ellipsoid zone loss and RP irregularity. Patients with drusen are mostly asymptomatic, and drusens appear as focal whitish yellow excrescences as seen here in this photograph, predominantly in the post-equatorial retina within the macula, and these excrescences appear to be subretinal in location at the level of RP Bruch membrane complex. Drusens can be classified based on size, border, number, distribution, and color. When considering the size of a drusen, the smallest diameter of the drusen is considered and compared with the diameter of a major retinal vein as it crosses over the edge of the optic disc, where the major retinal vein is usually 125 microns in diameter. And when the smallest diameter of the drusen is larger than this value, the drusen is classified as large. When the smallest diameter of the drusen is smaller than half this value, the drusen is classified as small, and in between, the drusen is classified as intermediate or medium. As regards the border or margin of a drusen can be classified as hard when it is well demarcated and soft when its margins are less well demarcated. And since size of a drusen correlates well with its border, with small drusens appearing hard and large drusens appearing soft, currently only size is considered to categorize a drusen for research purposes, because assessment of size can be done more objectively, and the color of a drusen can vary from white, pale yellow to bright yellow irrespective of its size. And as regards its distribution, although the number of drusens is the largest in the superior and temporal macula, the central ETDRS subfield, which is the central 100 micron diameter area, is the zone where the percent area involvement with drusen is the highest. As regards number of drusen, the involvement of the fundus with drusen can be minimal or moderate, and the numbers considered vary with the type of drusen. When the largest druse is small and there are fewer than 5 drusens, or when the largest druse is soft and indistinct and are fewer than 20 in number, or when the largest druse is soft and distinct and are fewer than 65 in number, the involvement of the fundus with drusen is said to be minimal, and when the respective numbers are larger than these, the involvement of the fundus with drusen is said to be moderate or extensive. And so far as drusens are considered, the total area of the macula occupied by drusen is the single most important clinical predictor of AMD progression, and this is important to remember. Over time, number of drusens may increase or decrease or change in appearance with respect to their size, thickness, and coalescence. And when Drusens regress, they become paler in color, decrease in thickness, have more distinct borders, may develop calcification, and usually develop atrophy of overlying retinal pigment epithelium, which is very important to remember. Hard Drusens, as seen here in this clinical photograph, have discrete and well-defined borders and are usually small, as we have mentioned, and majority occur temporal to the fovea and tend to occur in clusters without becoming confluent, which is a very important characteristic of hard Drusens. And when they come in contact with each other, they are called pseudo-soft Drusen, as they do not merge and remain separate. A few hard Drusens, as seen here in this photograph, is not associated with increased risk of advanced AMD, and this is very important to remember. And hard Drusens are seen very frequently, and more than 80% of individuals over 30 years of age have at least one hard Drusen. Soft Drusens, as seen here in this clinical photograph, have poorly defined margins and are usually intermediate to large, as we have mentioned, and they predominantly occur in the central macula, and unlike hard Drusen, even a single soft Drusen increases the risk of advanced AMD. And two types of soft Drusens have been described: soft distinct Drusens, which are larger and have more distinct margins, and soft indistinct Drusens, which are smaller and have less distinct margins. When two soft Drusens become contiguous with each other without a clear boundary between them, they are called confluent Drusen, as seen here in this clinical photograph, and they are also associated with an increased risk of advanced AMD. Soft Drusens larger than 250 to 500 microns, as seen here in this clinical photograph, are called drusenoid pigment epithelial detachments. They may have accumulation of fluid and thus appear translucent on retroillumination. They have a more regular topography as compared to fibrovascular pigment epithelial detachment, which occur in neovascular AMD. And drusenoid PEDs can cause moderate loss of vision more commonly than soft Drusen, even without progressing to advanced AMD. When drusenoid PEDs regress, clumps of hyperpigmentation and hypopigmentation develop, often in a radiating figure, over the drusenoid PED, and ultimately the elevation begins to collapse with or without development of geographic atrophy. Hard Drusen, soft Drusens, and drusenoid PEDs are the more common types of Drusen, and on fluorescent angiography, small hard Drusens typically show transmission hyperfluorescence or window defects. But soft Drusen, confluent Drusen, and drusenoid PEDs do not fluoresce in the early phase of the angiogram, fluoresce slowly and less prominently than hard Drusens, and sometimes show late staining. And Drusens, particularly drusenoid PEDs, may have blocked fluorescence due to surface hyperpigmentation. On indocyanine green angiography, small hard Drusens cannot be identified either in the early or in the late phase of the angiogram. But soft Drusens show hypocyanescence on ICGA as compared to the background choroidal cyanescence in all phases of ICGA, as seen here in this angiogram. Hard Drusens are not visible on fundus autofluorescence, but soft Drusens may show faint hyperautofluorescence at their margins or throughout, but areas of RPE atrophy result in hypoautofluorescence, as seen here in this photograph. On HD-OCT, soft Drusens appear as nodular sub-RPE elevations, usually with a homogeneous ground glass internal reflectivity and an intact overlying RPE. Overlying photoreceptor layer may show thinning with or without disruption of the ellipsoid zone. Few areas of hyperreflectivity may be detected within the neurosensory retina overlying the drusen due to intraretinal RPE migration, and we'll be discussing this further. Intraretinal and subretinal fluid is typically absent with drusens, but some large drusens and drusenoid PEDs may have overlying subretinal fluid in the absence of a macular neovascularization. And this is called exudative non-neovascular AMD, that is a non-neovascular AMD in which there is fluid within or beneath the retina. The subretinal fluid is usually located at the apex of the drusen or between two drusen. And in this situation, Octa helps in excluding macular neovascularization and thus can prevent unnecessary treatment. We will be discussing further about exudative non-neovascular AMD in the next session. And based on OCT, following drusen types have been described by AREDS. The most common type is the one with homogeneous medium internal reflectivity, but other types include those with a single hyporeflective core, those with a single hyperreflective core, those with multiple hyperreflective cores, and those with split cores having one portion hyporeflective and the other portion hyperreflective. Hard Drusens appear as slight elevations of the retinal pigment epithelium, and Drusens, both hard and soft, usually increase in size and volume before regressing, and following regression the involved area may develop atrophy, have no residual changes, or develop macular neovascularization. OCT measurement of area and volume of drusen is possible and is said to be an important predictor of progression to advanced AMD. And EDI OCT or SS OCT shows reduced subfoveal choroidal thickness in age-related macular degeneration. OCT-based high-risk features of drusen which increase the risk of late AMD include non-homogeneous internal reflectivity of drusen, particularly a hyporeflective core, hyperreflective foci within outer retina which indicate migration of retinal pigment epithelial cells within the retina, outer retinal atrophy, and choroidal hypertransmission. And on octa, choriocapillaris flow deficits can be detected below and around the drusen. Apart from these three common types of drusen, there are other forms of drusen also, which includes reticular pseudodrusen, also known as subretinal drusenoid deposits or SDD, which appear to be a pale yellowish interlacing network of individual soft drusens, which initially typically involves the superior macula and then involves the other quadrants of the macula with relative sparing of the fovea. On SDOCT, the deposits in SDD appear regularly spaced, flat to conical in shape, and lying anterior to the retinal pigment epithelium in the subretinal space, and this is where it differs from the more common types of drusen which lie in the sub-RP space. And as we have discussed in the previous session, SDD increases the risk of MNV type 3. Pachydrusen, as seen here in this photograph, belongs to the pachychoroid spectrum of diseases and occur in the sub-RP space, and unlike soft drusen, pachydrusen is associated with a thickened choroid and usually appears as a solitary lesion with well-defined edges. They are distributed in the posterior pole and are not concentrated in the central macula, and pachydrusen is said to be associated with polypoidal choroidal vasculopathy, also known as aneurysmal MNV type 1. Vitaliform lesions are commonly associated with pattern dystrophy and cuticular drusen, but uncommonly associated with age-related macular degeneration, and they are usually single and central in location, appearing as a yellow semi-opaque deposit with indistinct borders through which an area of hyperpigmentation may be seen within or posterior to the lesion. And vitaliform lesions are invariably hyperautofluorescent and show hypocyanescence throughout all phases of indocyanin green angiography. Cuticular or basal laminar drusens are also sub-RP in location and typically appear as innumerable small deposits as seen here in this clinical photograph, which are uniform, round and densely packed and are typically symmetrically distributed in the two eyes of the affected individual. They are characteristically found in younger individuals, and cuticular drusen is not related to age-related macular degeneration. Cuticular drusen typically show myriad hyperfluorescent pinpoint dots in early and late phases of fluorescent angiography as seen in this angiogram, which is called starry sky appearance. And on SDOCT, the deposits appear as blunted triangular projections of retinal pigment epithelium with their close spacing giving a sawtooth appearance. And among the drusen types, the principal precursors of late AMD are soft drusen and subretinal drusenoid deposits, and this is very important to remember. RP abnormalities is the clinical feature other than drusen which characterize the early phase of non-neovascular AMD, and RP abnormalities have been found to increase the risk of progression to advanced AMD irrespective of the nature of any associated drusen. RP abnormalities can appear as focal hyperpigmentation or focal hypopigmentation. Focal hyperpigmentation is more commonly located surrounding or anterior to drusen or drusenoid PEDs, and they can be at the level of the retinal pigment epithelium or more anteriorly within the neurosensory retina. Focal hypopigmentation, also known as non-geographic atrophy or incipient atrophy, have indistinct borders and appear lighter in color than the surrounding, but they can have associated pigment clumps surrounding or within the lesion. On fluorescent angiography, non-geographic atrophy shows diffuse transmission hyperfluorescence, but they are not as bright as geographic atrophy, and areas of hyperpigmentation show blocked fluorescence. And on ICGA, either no changes are apparent or an area of hypocyanescence corresponding to loss of choriocapillaries is seen. Areas of non-geographic atrophy, where there is loss of retinal pigment epithelium and its lipofunction, show hypoautofluorescence, and areas of hyperpigmentation may appear as hypoautofluorescence if melanin granules predominate or hyperautofluorescence if melanolipofunction predominates. Areas of focal hyperpigmentation show up as hyperreflective foci in the subretinal space and within various layers of the retina, as shown here in these photographs. These interretinal and subretinal hyperreflective foci are often located anterior to drusen, and the larger their number and the more anterior their location, the greater is the risk of progression to geographic atrophy, and this is important to remember. Geographic atrophy is one of the two types of advanced AMD and is the non-neovascular form of advanced AMD, accounting for 15% of severe vision loss from AMD. And it occurs when areas of focal RP atrophy enlarge or coalesce to a diameter more than 175 microns, but we must remember that atrophic patches can also occur in neovascular AMD, and as we have discussed, the total area of macula affected with drusen is an established risk factor of geographic atrophy. And longitudinal studies by the AREDS group have found the following preceding lesions at the site of future geographic atrophy: soft drusen, confluent drusen, RP hyperpigmentation, RP hypopigmentation, and refractile deposits. And the sequence of changes at the site of a future geographic atrophy have been determined to occur in the following order: drusen followed by hyperpigmentation, then drusen regression, and finally hypopigmentation before geographic atrophy develops. Clinically, geographic atrophy appears as a well-defined area of RP depigmentation through which underlying large choroidal vessels are more easily visible, and there is an associated loss of overlying outer retina and underlying choriocapillaries in the area of geographic atrophy, and this is very important to remember. The complications of AMD prevention trial found that 80% of geographic atrophy at diagnosis do not involve the foveal center, but non-central geographic atrophy may affect reading speeds without affecting visual acuity. These atrophic areas may expand to involve the foveal center, resulting in severe vision loss. And the AREDS group found that the median visual acuity at clinical diagnosis of geographic atrophy was 20/50 but worsened to 20/320 10 years after diagnosis. Geographic atrophy can also occur in a location where drusens are not present, and this type of geographic atrophy starts as an area of microreticular hyperpigmentation surrounding the fovea in a horseshoe shape, and then coalescing to become bullseye in shape with sparing of the foveal center, and finally involves the foveal center. On fluorescent angiography, geographic atrophy appears as a well-defined area of transmission hyperfluorescence, which is brighter than non-geographic atrophy but is not as bright as an RP dip, which occurs in neovascular AMD. There can be foci of blocked fluorescence around the margin of geographic atrophy corresponding to areas of hyperpigmentation, and the intensity of fluorescence decreases in late phase, and usually staining of the choroid and sclera may be visible through the geographic atrophy in the late phases of the fluorescent angiogram, as seen here in this photograph. In the early phase of indocyanine green angiography, there is a well-defined area of differential cyanescence from the background choroidal cyanescence, with decrease in choriocapillary cyanescence and greater visibility of larger choroidal vessels. And late phase of ICGA shows the well-defined area to be isocyanescent or mildly hypercyanescent, but in contrast, in Stargardt's disease, there is complete hypocyanosis of the macular area, which is called dark atrophy of Stargardt's disease, and thus ICG enables differentiation between Stargardt's disease and geographic atrophy. Fundus autofluorescence imaging of geographic atrophy is important, and geographic atrophy appears as a well-defined area of homogeneous hypoautofluorescence as seen here in this clinical photograph due to loss of RPE along with its liposuction. The surrounding area of sick RPE may appear hyperautofluorescent as seen here, and several patterns of hyperautofluorescence have been described in the junctional area between atrophic and non-atrophic retina. The patterns of junctional hyperautofluorescence can be divided into two groups. In one group, junctional hyperautofluorescence is restricted to only adjacent to the area of geographic atrophy, and in the other group, the junctional hyperautofluorescence is present both adjacent to the area of geographic atrophy and elsewhere in the surrounding retina. And it has been seen that eyes with either no junctional hyperautofluorescence as seen here in this photograph, or with focal junctional hyperautofluorescence as seen here in this photograph have a slow progression or a slow enlargement rate of the area of geographic atrophy. But eyes with banded pattern of junctional hyperautofluorescence or with any of the diffuse patterns of junctional hyperautofluorescence have a faster progression rate of the area of geographic atrophy, and the location of diffuse hyperautofluorescence surrounding an area of geographic atrophy also indicates the location which the existing geographic atrophy preferentially involves during expansion. And in patients with bilateral geographic atrophy, a high degree of symmetry of junctional hyperautofluorescence pattern has been found between the two eyes. On SD-OCT, geographic atrophy appears as a well-defined region, demonstrating absence of outer nuclear layer, external limiting membrane, and ellipsoid layer in the region of geographic atrophy, with absence or marked attenuation of the RPE-Brooks membrane complex and increased reflectivity from the choroid because of absence of pigment in the overlying retinal pigment epithelium. And this is very important to remember. Outer retinal tubulations or ORTs is another SD-OCT feature which can be found in eyes with either geographic atrophy or macular neovascularization as seen here in these two photographs, and they appear as small ovoid hyporeflective spaces in the outer nuclear layer with a hyperreflective margin. At times, hyperreflective material can be found in the hyporeflective core of an ORT, and on histopathology, ORTs show degenerate red-green cones and molar cells encircling the core of the ORT. ORTs may be mistaken as fluid of neovascular AMD, but fluid in cystic spaces is never surrounded by hyperreflective walls as is ORT. On SD-OCT, thinning of all choroidal layers are usually found in eyes with geographic atrophy, and OCT fundus images shows the area of geographic atrophy as a bright area due to increased reflection of light from the choroid in the A scans of the OCT. We have discussed OCT fundus imaging or OFIs in the session on OCT. Both these images are OCT fundus images or OFIs, with this one taken from the level of RPE and this one taken from the level of choriocapillaris. The classification of atrophy meeting proposed an OCT-based classification of geographic atrophy into incomplete RPE and outer retinal atrophy and complete RPE and outer retinal atrophy. Incomplete RPE and outer retinal atrophy is defined as a region of hypertransmission into choroid of less than 250 micron diameter with a corresponding zone of attenuated or absent RPE of less than 250 microns. And complete RPE and outer retinal atrophy is defined as a region of hypertransmission into the choroid of more than 250 micron with corresponding zone of attenuated or absent RPE of more than 250 micron. And definitions of both incomplete and complete RPE and outer retinal atrophy include evidence of photoreceptor degeneration but no evidence of retinal pigment epithelial tear or rip. On OCTA, choriocapillaris flow deficits are detected in the area of geographic atrophy. So this is the OFI image and this is the OCTA image at the level of choriocapillaries of the same eye. And on the octa image, the choriocapillaries flow deficits appear as dark areas, both within the geographic atrophy and surrounding the geographic atrophy. Geographic atrophy can be mistaken as macular neovascularization on octa because of segmentation errors on octa due to attenuated retinal pigment epithelium or due to forward shift of underlying large choroidal vessels into the space left by the atrophic choriocapillaries. We have discussed about segmentation errors on octa in the session on octa. And as we have mentioned before, octa helps to exclude macular neovascularization in non-neovascular AMD eyes with subretinal fluid. Geographic atrophy slowly but consistently increases in size, and the average rate of progression is estimated to be 1.79 square millimeters per year, and this rate varies significantly based on baseline size and adjacent junctional autofluorescence patterns. And foveus pair in geographic atrophy has been found to expand 2.8 times more rapidly towards the periphery than towards the center. Geographic atrophy needs to be differentiated from RPE of neovascular AMD, as both show transmission hyperfluorescence on fluorescent angiography. In RPE there will be a linear area of hyperfluorescence corresponding to the scrolled up edge of the retinal pigment epithelium at one of the margins of the hyperfluorescent area of the exposed choroid. AREDS classified AMD into 4 categories, and eyes with a few small or no drusen and without pigment changes are said to be in category 1 or no AMD, and eyes with extensive small drusen or non-extensive intermediate drusen depending on the total area of involvement are said to be in category 2 or early AMD. Eyes with many intermediate drusen, a single large drusen or non-subfoveal geographic atrophy are said to be in category 3 or intermediate AMD, and patients with unilateral advanced AMD are said to be in category 4. So we note here that eyes with a few small hard drusen are categorized as no AMD, and eyes with even a single large soft drusen is categorized as intermediate AMD. The AREDS study found that the 5-year risk by category of developing category 4 AMD is as follows: 0% in eyes with category 1 or no AMD which have either no drusens or only a few small hard drusens, and 18% in eyes with category 3 or intermediate AMD having many intermediate drusen or at least one single large soft drusen. And fellow eyes of eyes with category 4 AMD has a 43% 5-year risk of developing category 4 AMD. And it has also been found that eyes with drusen in the central and inner ETDRS subfields have a higher risk of conversion to advanced AMD as compared to eyes with drusen in the outer ETDRS subfields. AREDS also reported the risk of progression to advanced AMD in 10 years by type of lesion currently present. The risk is 1.5% in eyes with small hard drusens, but 36% in eyes with large soft drusens. And among patients with baseline large soft drusens who develop advanced AMD within 10 years, number of eyes progressing to neovascular AMD was 3 times more than number of eyes progressing to advanced non-neovascular AMD. And also, there are a few eyes which develop both geographic atrophy and neovascular AMD. And the risk of developing advanced AMD was even higher in eyes with both large and soft drusens as well as retinal pigment epithelial changes in both eyes. And patients with drusenoid PEDs develop geographic atrophy more frequently than neovascular AMD, and these risks become higher when the fellow eye has advanced AMD. As we have mentioned, geographic atrophy and neovascular AMD can occur simultaneously in the same eye, and AREDS reported that 16% to 32% of eyes with geographic atrophy progress to neovascular AMD depending on whether they had neovascular AMD in the fellow eye. And as we have mentioned, subretinal drusenoid deposits or reticular pseudodrusen are independent predictor of conversion to neovascular AMD, but the risk is much less as compared to the risk with soft drusens. AREDS also developed a severity scale to estimate the risk of progression. And the scoring method for the severity scale is as follows. 1 point is given to each eye having one or more large drusen, and to each eye having any pigment abnormalities. 1 point is given if there is bilateral intermediate drusen but without any large drusen. And if there is neovascular AMD or geographic atrophy in one eye, 2 points are given, but then the above scoring is not done for the eye already having neovascular AMD or geographic atrophy. The scores are then summed to arrive at a total score for the patient, which can vary from 0 to 4, and then the 5-year and 10-year risk of progression to category 4 AMD in one eye for that patient can be predicted according to this table. The final AREDS risk assessment model contained other risk factors in addition to those in the simple severity scale, but the magnitude of the effect of these other risk factors on the risk of progression to advanced AMD was much less than the simple severity scale itself, and these other risk factors included age, smoking status, family history, polymorphisms in CFH and ARMS2 gene, and presence of very large drusen. Differential diagnosis of non-neovascular AMD includes central serous chorioretinopathy and RP alterations following an episode of central serous chorioretinopathy may mimic non-neovascular AMD, and subfoveal choroidal thickness is typically increased in eyes with CSR and their fellow eyes, unlike in AMD where the subfoveal choroidal thickness is decreased. Other entities which come in the differential diagnosis of non-neovascular AMD include macular telangiectasia type 2, heel lesions of posterior uveitis, drug toxicities such as those from hydroxychloroquine, phenothiazines and canthaxanthines, and hereditary retinopathies such as Stargardt's disease and pattern dystrophies. As we have mentioned, in Stargardt's disease, ICG shows a dark atrophy in the central macula, which is not found with non-neovascular AMD, and in pattern dystrophies, the yellowish subretinal lesion on SDOCT shows up as a hyperreflective lesion between the retina and the retinal pigment epithelium, which on fundus autofluorescence shows central hypoautofluorescence and surrounding annular hyperautofluorescence. Management of non-neovascular AMD includes micronutrient supplementation, lifestyle changes, monitoring for deterioration, drugs, and rehabilitation. We have discussed in the previous session on physiology of retina that antioxidants play a protective role in retina, and AREDS study found that micronutrient supplementation is beneficial in patients with intermediate AMD and unilateral advanced AMD. So these are the two specific situations in which micronutrient supplementation is beneficial, and the supplementation includes beta-carotene, vitamin C, vitamin E, zinc oxide and cupric oxide. Cupric oxide is included to prevent zinc-induced copper deficiency anemia, and patients on micronutrient supplementation as compared to patients on placebo had a 25% reduction in risk of progression to advanced AMD in 5 years and 23% reduction in risk of progression to advanced AMD in 10 years. And the risk reduction was primarily that of neovascular AMD. Progression to GA was not affected by micronutrient supplementation. Micronutrient supplementation was indicated in patients with unilateral or bilateral occurrence of either single large drusen or multiple intermediate drusen or non-subfoveal geographic atrophy, unilateral advanced AMD or bilateral advanced AMD with better eye having a visual acuity of more than 20 by 100 with macular neovascularization. But supplementation was not beneficial in patients with no or early AMD, and this is very important to remember. The AREDS2 study confirmed that replacing beta-carotene with lutein and zeaxanthin was equally effective, as there were reports of development of lung cancer in current or former smokers on beta-carotene supplementation, but lung cancer did not develop in patients on lutein and zeaxanthin supplementation instead of beta-carotene supplementation in the AREDS2 trial. AREDS2 trial also found that there were no additional benefit of omega-3 fatty acids and confirmed that dose of 80 mg of zinc supplementation was appropriate. So the AREDS 2 formulation, which is now recommended instead of the AREDS formulation, is lutein, zeaxanthin, vitamin C, vitamin E, zinc and copper. Lifestyle changes which patients with non-neovascular AMD should be educated about include smoking cessation, obesity reduction, control of blood pressure and dietary modification, which we have discussed in the earlier session. Patients should be monitored regularly with regular retinal examinations in the clinic every 6 to 12 months, and periodic OCT and or fundus autofluorescence examinations is recommended for patients with geographic atrophy. And early recognition of symptoms of progression to advanced disease such as metamorphopsia and scotomata should prompt ophthalmic consultation when they occur. And home-based monitoring for these symptoms can be done either with AMSless grid or with preferential hyperacuity perimetry, which we have discussed in session 14 of this section. AMSless grid is said to have a low sensitivity in detecting onset of macular neovascularization in eyes with previously documented non-neovascular AMD, but preferential hyperacuity perimetry has been found to have a high sensitivity and high specificity to detect early onset macular neovascularization in eyes with intermediate AMD when performed in a clinic-based setting. And the home study demonstrated efficacy of home monitoring with PHP for early detection of macular neovascularization. But what is important is that home monitoring does not obviate the need for clinic-based examinations with ophthalmoscopy, OCT and or fundus autofluorescence, and this is very important to remember. Several drugs have been tried to reduce growth rate of geographic atrophy, and currently there are 2 drugs approved by FDA for this purpose, Pegcetacoplan and Avacincaptad. Pegcetacoplan inhibits complement factor C3, and the Oaks and Derby trials found that when compared to sham injections, Pegcetacoplan reduced the growth rate of geographic atrophy by 22% with monthly injections and 18% with every other month injection at 24 months in the Oaks trial, with replicable results in the Derby trial. Pegcetacoplan injections was found to cause neovascular AMD with an incidence of 12% in the monthly injection group and 7% in the every other month injection group as compared to 3% in the sham injection group. Other complications which have been noted with Pegcetacoplan therapy included intraocular inflammation and ischemic optic neuropathy. The other FDA-approved drug for geographic atrophy is Avacincaptad pegol, which inhibits complement factor C5, and the GATHER1 and GATHER2 trials showed monthly intravitreal injections of Avacincaptad reduced the growth rate of geographic atrophy as compared to sham injections. And like Pegcetacoplan, Avacincaptad was also found to increase the incidence of neovascular AMD. And brimonidine intravitreal implant has also been shown to reduce the growth rate of geographic atrophy in phase 2 studies. AMD patients often require surgery for cataract, which also occurs more frequently in this age group, and surgery is required when cataract contributes to the visual loss. Most AMD patients derive some benefit from cataract surgery depending on the stage of AMD, and it has been found that risk of AMD progression does not appear to increase following cataract surgery, but preoperatively it is important to detect and not miss AMD and prognosticate the visual gain following cataract surgery. Visual rehabilitation is important for patients with advanced forms of AMD, which can be provided with low vision services, and currently an implantable miniature telescope or IMT, as seen here in this photograph, is available. It is indicated in phakic patients with bilateral end-stage untreatable AMD, either central geographic atrophy or disciform scarring, who shows improvement in visual acuity with external telescopic device. It increases the magnification of the central field of vision by 2.3 to 3 times and has a 2-fold wider field of vision as compared to an external telescope. And following implantation, patients require visual training to alternately use the implanted eye for central vision and the fellow eye for peripheral vision. Endothelial decompensation and imaging of the retina are potential post-operative issues. To recap the salient points, non-neovascular AMD can be classified into an early stage characterized by Drusen's and RPE changes and an advanced stage characterized by geographic atrophy. Drusen's appear as whitish yellow excrescences at the sub-RPE level, and they can be classified by their size, margins, color and number. Hard Drusens are small in size, have well-defined borders, do not coalesce, and show transmission hyperfluorescence on fluorescent angiography. Soft Drusens are larger in size, have ill-defined borders, coalesce and show early hyperfluorescence followed by late staining on fluorescent angiography. Drusenoid PEDs are soft Drusens larger than 250 to 500 micron in size. On HDOCT, hard and soft Drusens appear as sub-RPE deposits causing nodular elevations of the RPE. Reticulate pseudodrusen or subretinal drusenoid deposits appear as an interlacing network of soft drusens, particularly in the superior macula. On HDOCT, subretinal drusenoid deposits appear as regularly spaced deposits anterior to the retinal pigment epithelium in the subretinal space and not the sub-RPE space. Drusens, particularly soft Drusens and drusenoid PEDs, may mildly affect visual function. Few small hard Drusens are considered as normal and not to increase the risk of late AMD, but a single large soft Drusen does increase the risk of late AMD. Soft Drusen, drusenoid PEDs and subretinal drusenoid deposits are the types of Drusen which increase the risk of late AMD, and the total area of the macula involved by Drusen is the most important risk factor of progression to late AMD. Following regression of a Drusen, the involved area usually develops atrophy of the overlying retinal pigment epithelium. RPE abnormalities can be in the form of focal hyperpigmentation or focal hypopigmentation and show blocked hyperfluorescence or transmission hyperfluorescence respectively on fluorescent angiography. On HDOCT, areas of focal hyperpigmentation appear as hyperreflective foci in the subretinal space or within the neurosensory retina. RPE abnormalities increase the risk of late AMD irrespective of the nature of the associated drusen. Geographic atrophy is the late form of non-neovascular AMD which contributes to 15% of severe visual loss from AMD. It appears clinically as a well-defined region of RPE depigmentation through which larger choroidal blood vessels are more easily visible. It is associated with loss of overlying outer retina and underlying choriocapillaries. Most GA initially does not involve the foveal center but may later enlarge to engulf it. On fluorescent angiography, geographic atrophy appears as a well-defined area of transmission hyperfluorescence with late staining because of more easy visualization of the staining of underlying choroid and sclera. On HDOCT, GA appears as a well-defined region where outer nuclear layer, external limiting membrane and ellipsoid zones are absent. RPE is absent or attenuated and choroidal hypertransmission is apparent. Outer retinal tubulations may be detected in the retina overlying geographic atrophy. OCTA shows choriocapillaries flow deficits in and surrounding the area of geographic atrophy. On fundus autofluorescence, geographic atrophy appears as a well-defined area of hypoautofluorescence due to loss of RPE and its lipofuscin. Surrounding areas may show junctional hyperautofluorescence whose pattern may predict the rate of expansion of the geographic atrophy and whose location indicates the direction in which the geographic atrophy is likely to expand. AREDS classified AMD into 4 categories with their 5-year risk of progression to late AMD. Category 1, also called no AMD, with few or no small Drusens without RPE changes who have a 0% 5-year risk of conversion to late AMD. Category 2 or early AMD with extensive small Drusen or non-extensive intermediate Drusen who have a 1.3% 5-year risk of conversion to late AMD. Category 3 or intermediate AMD who have many intermediate Drusen or at least one single large Drusen who have an 18% 5-year risk of conversion to late AMD, and category 4 or unilateral advanced AMD who have a 43% 5-year risk of conversion of the fellow eye to advanced AMD. AREDS also developed a severity scale which enables coding to predict the 5-year and 10-year risk of progression to late AMD. Differential diagnosis of non-neovascular AMD include retinal pigment epithelial changes following central serous chorioretinopathy, macular telangiectasia type 2, healed posterior uveitis, drug toxicities, and hereditary retinopathies such as Stargardt's disease and pattern dystrophy. Management of non-neovascular AMD include micronutrient supplementation with lutein, zeaxanthin, vitamin C and E, zinc and copper, lifestyle modification with smoking cessation, obesity reduction, control of blood pressure and dietary modification, drugs, particularly complement inhibitors, Pegcetacoplan and Avacincaptad pegol, monitoring with Amsler's grid and preferential hyperacuity perimetry, and visual rehabilitation with low vision devices and implantable miniature telescope. Cataract surgery has been found to not increase the risk of progression of AMD. Thank you for listening.